Welcome everybody to the HP Dialogues. So we're very pleased to have Dr. Tejinder Singh sir with us. He's going to be discussing on writing case-based MCQs. He very strictly said, do not go for any introduction. Of course, he doesn't need any introduction. But for a few of us who are new, he's the chair at the Center for Health Professions Education at Adesh University, Bathinda. He's also an NAMS Emeritus professor. I yield the floor to you, Tejinder sir. It's all yours now.
Thank you very much. Namaskar, Devio or Sajjano. It's a pleasure to be talking to this elite gathering. And I thank Chetna and Jyotsna to give me this opportunity to come and discuss some things with you. Now, although the interest in scenario-based, case-based, vignette-based, whatever name you want to give them, MCQs has been going on for quite some time, maybe last 30, 40 years. But I think with the introduction of the new curriculum and the emphasis on scenario-based MCQs and a decision to have more such questions in NEET and next has probably stimulated everybody's interest and imagination. I must say that the construction of MCQs that we generally tend to see in our examinations, including high-tech and high-end examinations like NEET and next, are not really, I would say, state of the art. They need much improvement, they leave much to be desired. And once we start writing scenario-based MCQs, then probably the problem is going to get exaggerated, and we'll have to look for avenues to make sure that the questions and items that we are giving to the students really meet good educational practices. Now, while I was preparing for this talk, in fact, I just searched the net to find out how to crack MCQ exam. I didn't write without knowing, but I'm sure in most of the results that I have got, the heading is how to crack an MCQ exam without knowing. And you'll be surprised at the number of results, 1.4 crore results. Some of them may be duplicate, some of them may be just fraud websites, but many of them are actually good websites which give a lot of information. And I actually culled some of the resources, and I particularly am impressed by this book, Rock Breaking Scissors, which gives very practical, down to earth solutions for cracking an MCQ even when you do not know the answer. Now, writing scenario based MCQ is no reason to bypass the general principles of writing good items. We cannot say that since we are writing scenario based, so some flaws are okay, acceptable, it's all right. Probably we can't take that line. I'll just illustrate it with a simple example. When you have a camera without an optical zoom, it's easy to take a picture. Anybody can just click and you'll probably have a good acceptable picture available. But when you have a camera with say 3x or 5x optical zoom, then the chances of your hand shaking and picture blurring are much more. And probably something similar happens when you are writing scenario based MCQs. The item writing flaws which we make while writing simple recall type of questions may go unnoticed. But when you have a scenario based question, then these stand out very aggressively. And I'll give you some examples as to how a person who doesn't even know the answer actually can exploit the weaknesses that we leave for the students to work on them. Interestingly, when people talk of NEET, G, and other similar examinations, they don't say passing the examination. The term they use is cracking the examination. So probably it requires some other skills also in addition to knowledge to really get more marks, get higher score, go to a higher percentile, and so on. And so the purpose of today's presentation, and I am aware that this is not the best format for actually training the audience in writing scenario-based MCQs. At best, I can only sensitize you, because it requires a hand-on experience with each one writing questions, and then those questions being scrutinized and modified and so on. So it's a long process, but definitely today I can sensitize you to the process of writing scenario based MCQs, what are the common flaws which appear, and how can you take out those things to make questions educationally acceptable. Just look at one simple example. If I give this recall type of question, uh, somebody has scribbled on the screen. Can you please take it off? Thank you.
I'm trying, sir. I'm doing that.
Thank you. Okay. Now, if you give a traditional question, for example, a mandibular nerve is 1, 2, 3, 4. Now, it's difficult to make a guess. Unless you know something about it, you won't be able to make a guess. But if somebody was to give a case-based MCQ like this, then you can easily make out fine motor skills and then developmental coordination disorders. So guessing becomes accentuated. Even otherwise, longest answer is the correct answer. Even that formula you can apply and come to the correct answer even without reading the question. So therefore, it is very important that when you write scenario-based MCQs, then you take care to plug all such loopholes which the students can exploit to answer the question correctly, even when they do not know the correct answer. Now, we all know the function of assessment. We are using it as assessment of learning, assessment for learning. A rather neglected aspect is assessment as learning. And I can tell you that in this era of competitive examinations, in fact, MCQs have become the primary mode of learning for many students, especially because the things that are asked in the entrance examination are never taught in the classroom. So MCQs remain the best source of knowledge. And this assessment as learning function, although it is unintentional, we have not planned it that way, but it can actually distort the learning of the students. In one of the mails that Dr. Chetna had shared with you, I had given a paper, PG entrance examination for dummies. It was written by some faculty from AIMS Delhi. And if you go through that paper, you'll find out how students try to learn for answering MCQs, because many of the things which they have to answer in those competitive entrance examinations are not really covered in their formal or informal curriculum. So keep it in mind that students are not simply going through MCQs to only assess how much they know, but they are also going through those MCQs to learn many things. And that is where the catch lies. Now, if your MCQs are not helping the students in that part, or if the MCQs are providing a wrong information to the students, then probably a distorted learning is happening. And that can persist for a very long period of time. We heard assessment drives learning, and it's well known that for a student, what is written in the MCQ answer book is gospel truth and not what is written in the textbooks. Interestingly, and that's my personal observation, if you look at the multiple MCQ books which are available in the market, which claim to be, having questions from NEET and AIMS and this and that and all that, most of them are actually written by either residents or students who have only themselves appeared for the examination. no serious effort is gone in making those questions for those books. So if you put a wrong question and a wrong answer, then you are distorting the learning of the students. So please keep that in mind, that a large amount of learning is happening as a result of going through these MCQs. And I'll come back to this part at the end of my talk, because that is where we can actually positively exploit it to our advantage. Now, when we say using MCQs, traditionally we have been using it for assessment of factual knowledge. What is the length of colon? What is the weight of liver? How many lobes are there in right lung? So you just want factual knowledge from the student, and especially in the early part of the curriculum, that is what the function of MCQs actually comes. But if you climb up the Bloom's taxonomy, then what you find is that levels like applying, analyzing, evaluating, they can also be assessed, provided you frame your questions accordingly. And so, incorporation of layered scenarios, and I emphasize this word, please take this as one of the carry homes, layered scenarios within the stimulus format. Now, this is another word which I'm going to describe shortly. Stimulus format followed by a lead-in question to assess understanding and application. So, except for the highest level of Bloom's, that is creating, which possibly cannot be tested by MCQs as of now, but most of the other levels of Bloom's can be actually tested by writing good quality case-based, vignette-based, or scenario-based questions. Now, if you look at what happens to once people submit their questions, even in the best institutions, the item writing flaws have been reported between 37 to 72%. That means in some scenarios, almost three-fourths of the questions which are produced will have some flaws. When I say flaws, it does not mean that they will be straight away discarded. Maybe they need improvement, maybe they can be made all right. But almost three-fourths of them actually need something to make the questions acceptable. And so, don't feel depressed if on peer review, some issues or some problems are pointed with your question. And this is from some of the best institutions. In fact, this high figure actually comes from National Board of Medical Examiners, US statistics. Even they have this high rejection rate. Now, if you look at what happens then, is that a flawed MCQ can actually have both positive and negative effects. Positive, it can give a clue to the student. It can teach him something new which he didn't know already. And negative, that he can guess the answer and he can get higher scores. He may pass, although he may not deserve to pass, and so on. And the worst part is that it is always the high performing students who are affected more by item flaws as compared to average students. Average students generally don't have a problem. They'll skip through. They will even overlook minor issues in construction of MCQs. But when you have high performing students, they start analyzing, they start dissecting the questions, and in the process, they'll end up with something that in spite of knowing, they may not get credit for the question which they have answered. And therefore, it is essential that item flaws are actually taken care at every stage. When you write, when the question is initially peer reviewed, when a question goes to the expert group, when a question is scrutinized later on. So one has to make efforts to take out the item flaws so that high performing students do not get unnecessarily penalized because of the flaws which have crept inside the questions. Now, if we look at the general issues, general problems with MCQs, You can divide them into two broad categories, and this was done by Downing and Haladina, two of the very well-known names in the field of multiple choice questions. So when we say test wiseness, that means the students learn how to crack the question based on various issues. And what those issues could be, there could be a grammatical clue, is or an, for example, would give a clue to what is the right answer. When you use absolute terms, it never happens, it always happens. So the student knows that this is not correct. When you say usually, sometimes, then they know that is probably the correct answer. Third, and this is really important, this is that long answer is generally the correct answer. Why this happens, I'll come to a little later. Then there is a clang association. One example I gave you, something in the stem gives you a clue to one of the options. I'll give you some more examples. And then there can be convergence strategy. This is one of the very interesting things which one can learn. And in fact, I learned this technique, and now it is one of my favorite pastimes. When I don't have anything else to do, I would open a MCQ book and try coming to the correct answer without even knowing the subject matter. I'll show you, you can do it easy. The second group of problems is what are called irrelevant difficulty. Irrelevant difficulty means when you try to unnecessarily make the question verbose. So when you have, for example, normal duration of pregnancy, so you start with 280 days, 270 days, 290 days. So when the student has to jump up and down to really come to a logical conclusion. Or sometimes when you use vague terms. I came across one of the publications where they actually tried to look at what does the term usually mean. Now, when you say the term usually, in various publications, right from 30% till 80%, people have used the term usually. Same thing happens with sometimes, sparingly, never. So when you use these terms, you are confusing the student. Sometimes there may be non-parallel language. So grammatical clue will tell you what is the correct answer. And then, of course, we are all aware of this none of the above and all of the above. We'll discuss this also a little bit when we come to the framing of options and distractors. Now, I told you that correct answer is generally longer than the distractors. And since we are taking correct answer from a source or a book, so generally we tend to take textbook wordings for the correct answer. But distractors are not there in the book. So you have to frame them on your own. And so you use your language. So that difference can actually be picked up by the students. And sometimes when you use always, never in the correct answer, but you don't use them in the distractors, is another giveaway when the students can actually guess as to what could be the possibly right answer. On the distractor side, when correct answer and distractors are not homogeneous in content. One classical example would be that the correct answer relates to the treatment, whereas distractor relates to the investigations. Now, that is where the problem starts. The grammar of the distractors doesn't match the grammar of the stem, and the distractors are shorter in length compared to the correct answer. Now, all this happens with a reason. It's not my, I would say, figment of imagination. In fact, these things have come out after a lot of research which has been done on the examiner behavior as to how do they write MCQs, and then we get a lot of information about these ideas. Now, I told you the term stimulus format. Now, here is one question where you give a stem and then you put certain options. Now, what we have done, this stimulus on which the student has to respond is totally non-contextual. It doesn't help the student in learning better or managing the patient better. But if we change the stem to something like this, now what you would notice that the response which is expected from the student is same in both the cases. What has changed? The stimulus has changed. And why do we need to have this stimulus format rather than response format? Is because in actual practice, when the patient comes to a doctor, he doesn't come questioning him, doctor, what is the most important cause of pain in my abdomen? He will come with a history. You might find certain things on examination, and then you make the diagnosis. So this format actually is more closer to the actual work that the student is going to do in real life. And therefore, it prepares the student better to face clinical decision making, to face clinical scenarios, to come out with sound management decisions, and so. Again, before going to the next slide, I'm emphasizing here that in both the situations, the response that you expect from the student remains the same. It is only a difference in the stimulus. And if you want to call it, you can call this a scenario based. So in effect, a scenario based uses a stimulus format, whereas a recall type of question uses a response. Now, if you read the Australian Medical Council's guidelines, what it says is that the MCQ examination focuses on, and these are the important things which I want you to notice and remember, focuses on basic and applied medical knowledge. So that is the first thing which you have to do from MCQs across a wide range of topics and disciplines. Second, it should involve understanding of the disease process, clinical examination, diagnosis, investigation, therapy, and management. And then it goes on to add that it should also assess the candidate's ability to exercise discrimination, judgment, and reasoning in distinguishing between the correct diagnosis and plausible alternatives. So it's very clearly stated that purpose of MCQ is not just factual recall and basic knowledge. In fact, you have to go right up to assessing the ability to exercise discrimination, judgment, clinical reasoning skills, diagnostic skills, and differential diagnosis. So keep this in mind when you frame an MCQ. Don't stop at a simple MCQ just asking the factual recall, because that would probably defeat the whole purpose of this exercise. Now, if you compare the traditional with case-based MCQs, some things which stand out are that while recall type of questions are useful maybe in your classroom teaching, for example, after teaching on certain topic, you can project some questions about recall, which will help the students to recap the information. They might also help them to know what was important in today's topic and so on, what is called attention keeping strategy. But when you move on to case based or scenario based, and my apologies because I used case based everywhere, although Chetna said I should be using scenario based. I'll be more careful on that now. So when you use a scenario based question, then actually you are encouraging a problem based learning. You are promoting clinical correlation between the raw data and the diagnosis. You are promoting application of knowledge, and you are promoting clinical decision making. Now, this is something which we generally tend to miss out. And I'll show you in subsequent examples as to how you can incorporate all these when you write your MCQs. A very recent publication comes out with the advantages of scenario-based MCQs as integration of theory and practice, assessing the higher order knowledge, improving the clinical readiness of the students. They help the student to enhance the contemporary pedagogy, and the most important, that they enhance the proficiency in differential diagnosis. What it means is that your distractors should actually be the items which you want the student to include in the differential diagnosis. So writing a distractor probably requires as much time, effort, and imagination as the key. In fact, writing the key is very easy. You can just take it straight away from a book or a reference or a journal. But writing a distractor actually requires a lot of ingenuity and a lot of imagination. Let's look at this question. A typical response format. There's no stimulus. So the most likely renal abnormality in children with nephrotic syndrome is, so you have given 4 options. And the answer is minimal change, nephrotic syndrome. Otherwise, it appears to be a good question. There is no scope for guessing, no absolute terms used, no grammatical errors, etc., etc. But the interesting part is that if you use this question, then you end up with a discrimination index of 0.01, very low in the scale. Now you add a little scenario to it. Options remain the same. And once you use this type of a question, your discrimination index jumps up to 0.16. Not only that, you further increase the scenario, add more things to it. Options remain the same, and the discrimination index now is 0.32. And this comes out of the National Board of Medical Examiners research on the length of the scenario versus discrimination index. And I hope you have taken note of that in all the 3 types of questions, the response remains the same. And this scenario provides a typical example of the term that I used earlier, that is layered vignette. So you are wrapping the diagnosis in various layers of history, physical examination, laboratory investigations, etc., etc., and then asking the student for a likely diagnosis. So please remember this layered vignettes, which are the, I would say, heart of writing a good scenario-based multiple choice question. So the recommendation for writing scenario-based question is that they should include a contextual vignette, which I'm sure many of us would like to add. More importantly, a clearly defined, positively phrased question, and 5 homogeneous, concise options, one of which is clearly identifiable as the single best answer. 2 things I want you to notice. One, that we are talking of a single best answer. We are not talking of a correct answer. When a child presents with fever and pain in abdomen and vomiting, enteric fever becomes a possibility. But viral hepatitis is equally possible. Maybe less than enteric fever, but it is a possibility. So it's not that the other options have to be wrong. And as I said earlier, these MCQs should help the student to make a good differential diagnosis. And once you are putting a differential diagnosis, then it cannot be wrong. Only thing is its probability will go down. So this is the first thing I wanted you to notice. Second thing I wanted you to notice was that these should be concise. I have told you one of the problems with distractors and options is that longest answer is generally the correct answer. So if you make it concise, then you are actually taking that clue away from the student. And third, you may have noticed that it says about 5 options. Now, this is a kind of policy decisions because most of the American and European MCQs you will see generally have 5 options. India, we are traditionally working with 4 options. And I remember a paper which Avinash and Rashmi had published in National Medical Journal and which reviewed the literature extensively to come out with the recommendation that 3 well-written options are as good as 4 options. That means they don't encourage guessing. That is what we would think, that lesser the number of options, more would be the guessing. But then they reviewed the literature to show that even 3 options, provided they are well written, are as good as using 4 or 5 options. The advantage with 3 is that it is very easy to write 3 because one is correct answer, key, that you have anyway written. The other 2 you can write, but once you have to write the third distractors, don't know, don't really write anything. So what, distractor ही तो है. And when it comes to writing the 5th distractor, oh my God, you can never finish that. So for that reason, 3 actually is gaining momentum, and many places are actually now shifting over to the 3 options. Anyway, we leave it to the policymakers to decide what they want to conduct. But since we are all well versed and using 4 options for quite a long time, so I believe that it will probably continue for many more years to come. Now comes the most important part, and that is the research on how examiners write the items. And if you look at the examiner behavior, it can give you a lot of clues about how to improve your item. Now, when suppose I am asked by some university or some board to write MCQs, then what I would do is think of a topic, content area, problem, or maybe they would already give me these are the topics and these are the problems on which you have to write the MCQ. Next, write the stem, add information to it, some history, some physical examination, some laboratory values, but pose a straight question. And I'll show you some examples how examiners write these questions. Then you write the correct answer and provide as much information to make it correct, because that has to be unarguably correct. Nobody should be challenging your key that this is wrong or some other distractor was the right answer. And since you have provided, you have to provide all the information to make it correct. Keep that in mind. That is where the problem starts. When I come to some examples, I'll revert back to this part to explain to you what can be done about it. And then we think of distractors. And the interesting thing is, how do you think of distractors? You already have the correct answer. And then you keep on tweaking, remove one word, remove one phrase, remove one value, add one value, do something. Because most of your distractors are actually a modified version of your correct answer. Because that is where you think the student will make mistake. So one clue can actually come out from here, the longest answer, and the answer which provides most information, or the answer which provides a textbook wording, would be the correct answer. And distractors are only a modification of the correct answer. And then what happens in that modification is we often tend to create a distractor which nobody would think is all right. Simple example, if you have a question on what is the weight of a normal liver, and then you may have 500 grams, 700 gram, 1 kg, one of the distractors might be 5 kg. Nobody picks it up. So you lose an opportunity. And that is, I go back to the number of distractors. It's better to have 3 options with 2 well-written distractors than to have 5 options with 4 distractors which are not serving any purpose. Now, contrast this to how students answer MCQ, because that is another area which will give you a clue regarding making good questions. Now, what the student will do once he is presented with a question, so he will read, he will interpret and try to understand what is being asked. Please remember that knowledge organization in our mind is around concepts, not around facts. So in other words, if you ask about one particular patient, probably he may not be able to answer. But if you say in general, then he has that information stored in his mind. And having understood what the student does, he has a lot of stored what we call schema or scripts in his mind. He may have read about it, he may have seen those kind of patients, he may have heard about those kind of patients from his seniors, teachers, and so on. And then his brain quickly scans the stored schema to find out a correct answer. Or if I put it very simply, in a good quality MCQ, the moment the student understands the question, the correct answer should flash in his mind. And once that answer has flashed, then the task is simple. He simply has to match that option with the options that have been provided and come out with the correct answer. Now, that is the way a student would approach a multiple choice question. I hope you noticed the difference between how you write and how students approach. And these two are very well researched aspects of MCQ testing. Yet another thing which you need to keep in mind is that students have one mind irrespective of the number of subjects. So they would approach the MCQ with the same mindset, whether it is from physiology, or it is from pediatrics, or it is from medicine, or it is from surgery. I remember this kind of confusion used to happen many years ago, say about 25 years or so, when I had just joined as a lecturer at the CMC. And then, pediatric would teach one immunization schedule, community medicine would teach another immunization schedule, medicine would teach yet another model. So when the students had that question, write the immunization schedule, invariably somebody would stand up and say, sir, which subject's schedule we have to write? Now, students have only one mind. And please also remember, and that is very important to keep in mind, is that the ultimate purpose of all this assessment, testing, MCQ, etc., is that the student should be able to make a correct diagnosis and plan appropriate management. It is not that he should acquire facts in physiology and facts in pharmacology and facts in pathology. That's not the purpose. He should know facts. But the purpose is that he should be able to apply these facts to make a diagnosis and to plan a better management strategy. Please keep this in mind. So many of the times when I see some questions, the typical answer I get is, oh, ये तो anatomy के question है, ये तो ऐसे ही होंगे, ये तो pharmacology के, ये तो ऐसे ही होंगे. So that probably is not the way to approach MCQs, because ultimately, why are we teaching anatomy or physiology or pharmacology? So that he becomes a better clinician. So ultimately, everything has to relate, and as such also, if you see, all the scenarios would actually be a clinical scenario. So all this basic sciences knowledge, the student should be able to apply to that scenario and come out with a good diagnosis and a good management plan. When you have scenario-based MCQs, there is a slight difference in the answering process. For the recall questions, I told you what the student has to do. Largely, it would be following the same steps, but here what happens is that you are giving a brief scenario to simulate a clinical condition. The student has to make a diagnosis based on the information provided and then select an appropriate intervention and treat. Again, I want you to recall the term layered vignettes. So you are wrapping the diagnosis in multiple layers of information from which the student has to actually pick out the most important ones. Now, many times what happens is that we write a scenario, we ask a question, but this in between step is actually missing. I'll show you some examples to make it more clear. But please remember, the purpose of a scenario-based MCQ is actually a two-step process. One, his ability to make a correct diagnosis, and two, his ability to plan or select an appropriate intervention or treatment. Now, if you are not making use of this purpose of scenario, then we are missing on a lot of things. Then it is only a recall type of question to which we have added some window dressing and some seasoning and served it to the student. But it will not serve its intended purpose. There can be many issues in scenario-based MCQs. The common ones being over-reliance on recall. You give a scenario, but the stimulus that you give to the student calls for only a recall. Sometimes there could be misleading distractors, and that is actually important, especially because, as I said, a lot of learning happens from MCQs. So if you are focused only on one particular distractors because you are teaching that way in your subject area, then we are resulting in a wrong learning. The stem might not be clear. Sometimes, there can be over reliance on one single best answer when there are more than one answer is possible. And we offer some very limited options because we don't want to really have a situation where there can be too much of overlap between the key and the distractors. Now, I happened to see some MCQs on iron therapy, and the common theme was the patient fails to respond to oral iron. These were the questions, one of the questions, and the correct option was she might be taking antacids. Remember, 42-year-old female presents with anemia, given iron treatment. After 1 month, there is no improvement. And the option that we are giving to the student is that she might be taking antacids. Then I searched further. And what I found is that most of the questions on this aspect were actually related to like this. The medicine was taken after food, the dose was not all right, she was taking antacid, and something which was causing problems. But as a clinician, I wonder if I get a similar situation, what would I think of? Would I think of antacids or antisebum or postsebum? Or would I think of more serious issues? Wrong diagnosis, continuing blood loss, malabsorption, worm infestation, most importantly, malignancy. Would I not think of these things? So if you do not put these into your options, then you are making a very myopic vision, not only for your question, but also for the student. When he sees a patient in future, he would be stuck only on these parts. He would never think of ruling out a malignancy. Now, I understand that this is important for your subject area, for example. You have to teach this. True. But then your STEM should actually include all these. For example, continuing blood loss was ruled out, she was dewormed, there is no malabsorption, there is no evidence of malignancy. Now what will you? So you have conveyed to the student that if a patient presents like this is what you need to do. So this will increase the length of your STEM. And if you have noticed recently, in fact, from earlier trend of having only one line or one word as a stem, mandibular nerve is, that was all for stem. Vibrio cholerae, finish. That was the stem. And long options beneath that. We are actually moving to a situation where you have a long and longer stem and short and shorter answers. Remember the term I used earlier? Concise answers. Take another example. Now, I could guess that most likely it was about concomitant administration of sildenafil. And that is what the item writer actually wanted to test, that if you give nitroglycerin with sildenafil, then there can be hypotension. But if you look at this stem, how many inconsistency you can detect here? A 38-year-old male presents with the typical cardiac pain, and the medical officer immediately administers nitroglycerin supplement, after which the patient collapses within 10 minutes. Please notice, even an ECG has not been done. So if I am encountered with this kind of a situation, my first response would be, did the patient suffer a massive MI? Was it MI which caused the patient to go into hypotension? I won't think of sildenafil as the first thing. And so, according to me, the right answer would be D. Administration of nitroglycerin itself was wrong because we didn't confirm whether it is angina or it is MI. Now, keep these things in mind. For your subject area, yes, I agree. That is what you have to teach. But please remember that you are causing a learning for the student. And when a student encounters a similar situation later on in actual life or actual practice, then he would probably still be thinking along a concomitant drug therapy rather than trying to figure out whether it was a severe MI, which he missed in the first place because he didn't do an ECG on the patient. So what are the guidelines for writing scenarios? And these come from National Board of Medical Examiners, US 2019, the latest uh, version of their guidelines. What they state? That it should test application of knowledge to pose medical decisions. Second, and that's important, that it should focus on common or potentially catastrophic problems. And the question that I have shown you just now, it was MIA, which was more of a problem than another drug administered along. So common or potentially catastrophic. And some of you who remember the steps of blueprinting would recall that I and P, the incidence and preventive potential, which should be the paramount factor in deciding what should go in the scenarios. At the same time, avoid zebras, unclear situations, and esoterics. You saw one rare case in all your life, and then you make a question on that case. Well, it doesn't really make sense, because there is a common saying that if you make rare diagnosis, you would rarely be correct. Make common diagnosis. And also remember to avoid clinical situations that a specialist would handle. Pose only those problems which a graduate has to deal and address. And also focus on the common clinical reasoning mistakes. That means differential diagnosis, treatment plan, and so on. So, what do you do before you start writing scenarios? You decide the topic, develop the case, as far as possible, have authentic situations, although you can use hypothetical. So, one of the best ways which you can do is that after every case presentation, ask your resident to write 4 lines or 5 lines about that patient. And that can easily be modified into one scenario. Because writing on authentic cases is easier. Creating hypothetical situations becomes difficult because then you tend to go to extremes. They should be absolutely correct or absolutely wrong. Whereas in clinical practice, you may not have that advantage of going to absolutes. You frame your questions, which should test understanding and application. Have distractors. That is one of the most important issues with MCQs, whether recall MCQs or scenario-based MCQs, because the distractors have to be conceivable, coherent, and non-deceptive. You don't want to make a mental game with the student. That can he guess what I am guessing? It should be something which a normal physician would think in those times. And some of the very good sources of distractors, I recently saw one paper from Manipal where they actually used computer-generated distractors. You can Google on Manipal University MCQ distractors, and you would get that paper. Some very good, interesting ideas. Second is to use short answer questions in your day-to-day teaching. And these short answer questions actually provide you some very good quality distractors because they represent the common misunderstandings that the students have. And the very recent trend of using very short answer questions, where the student is required to write only maybe 1 line or few words at the most, and which can serve as a very good option. And the wrong options can actually create a good distractor bank for you for use in your day-to-day situations. Now, authenticity of cases is important. That should be something which you have taught, which they have seen. It shouldn't come something out of the blue. They shouldn't feel, oh, we never see this, we have never seen this, we will never see this. Why read about this? Then precision and clarity of language, distractors, and you would be surprised at the number of times I have actually emphasized on distractors. There should be incorporation of clinical reasoning. There should be some mechanism to provide them feedback. And then, of course, you have to evaluate and validate the MCQs that you create in the first book. Now, I'll not read through this. Some of it we have already discussed. But what I want to say here is that in general, you should be moving from symptoms to findings to diagnosis or treatment. Don't move the other way around. So if I give an example, so a patient suffered an injury on his shoulder and he is not able to lift his upper limb. On examination, there is swelling. You can describe where. So what is the diagnosis? Because that is what will resemble the actual clinical situation. That is how the patients will come to the doctor. Rather than going other way around, what are the features of injury to brachioradialis? No patient will come and ask the doctors about the signs and symptoms related to a particular diagnosis. So please remember to move from symptoms to findings to diagnosis, rather than diagnosis to symptoms. Now, that's a important thing for you to keep in mind. And please focus on the patient and the problem. Don't focus on your subject. And therefore, one of the key takeaway is that please involve your clinical colleagues if you are writing for basic sciences and vice versa. Because when you are teaching basic sciences, your focus is on your subject area. There may be certain nuances of clinical practice. There may be certain small tricks and tips of clinical practice which you will not be teaching. But your clinical colleagues can actually help you to build those into your MCQs. And once those are built, then definitely the quality of your MCQs will go down. Another strategy which I came across is to write the scenario, write the question, and ask your colleagues to provide answers. So if you have asked your postgraduates, for example, to write a scenario after a case presentation, give it to some other colleague and ask them to provide options without you giving any clue as to what could be the possible answers. Now, here is an example of a simple patient vignette. I won't read this, but I'm sure you can notice that we are talking of a patient with symptoms, then signs, then investigations, and then moving on to the diagnosis. So, on an average, a good scenario would have age and gender of the patient, site of the care. For example, it is a primary health center or a tertiary hospital or your office, wherever. The presenting complaints, the duration, and then you can provide some additional history, like physical findings, lab reports, response to initial treatment, and so on. Now, Case and Swanson have actually given a number of such templates, and you can use these templates to frame your question. For example, a patient description, 20 years old male, 10-year-old child, 15-year-old female, whatever, is unable to You can say rise from the bed, or close the eyes, or lift weight, whatever thing you want to test, and then which of the following is most likely to have been injured. So you have provided a context, you have provided the information, and now you are asking for committing to a diagnosis. You could ask for diagnosis, you could ask for treatment, you could ask for prognosis, you can ask for so many things in this situation. Now, the same thing, same template employed here. So, a 65-year-old man, difficulty rising from a seated position and straightening his trunk, but no difficulty in flexing the leg. Which of the following muscles is most likely to have been injured? The gluteus flexors. Now, you can keep this template and modify it. You can do it at school-going child who went to play football and had an injury, a ball injury, and now he has a problem with these movements. So what is likely to be injured? You could do it to a 20 years adult who was running to catch a bus, suddenly he fell down, and now he's not able to do this. So what is likely to be injured? So the same template actually can be used for a number of scenarios and problems. And here are certain others. So type of injury could be there, or you could give history and past treatment, and then you could give some physical examination or laboratory findings. Or yet another is where you can write some abnormal findings and then ask for which additional findings would you look for to suggest a diagnosis of, say, typhoid versus hepatitis A, and so on. A look at these templates tells you that they are grounded in an actual clinical scenario. So they don't look like a hypothetical situation. They are real situation. And they are layered. So they don't present the diagnosis straight away. Rather, they provide information in a layered way, expect the student to make a diagnosis, and then come out with treatment or further confirmation or prognosis or whatever aspect of the disease you want to ask. Some others you can see here, for example, a dietary regime in a patient, which of the following conditions? So you could ask about vitamin D deficiency, you could ask about B12 deficiency in vegetarians, you could ask about thiamine deficiency or folic acid deficiency in a patient who is taking rifampicin or other drugs. Then you could also ask the mechanism of action of drugs. Please remember, this could have been asked straight away also. But now you are asking this in the context of this. So, like I remember we had a patient of nephrotic syndrome who was also being given rifampicin, and because of rifampicin, there was some hepatic enzyme induction causing early metabolism of steroids, and the patient relapsed. Now, we could straight away also ask what is the effect of rifampicin, but giving a scenario like this and then asking about the possibilities makes it more authentic. Sometimes you can actually try to convert the existing questions to scenario based questions. So if, for example, you pick up this question somewhere, that which area is supplied by posterior inferior cerebral artery, and you could also convert it like this. So give a brief history and then ask which artery is most likely to be affected. The basic philosophy remains the same. The patient would present like this. He would never come to question you on anatomy or physiology. Now coming to STEM, and in fact, for scenario-based questions, actually STEM becomes the most important part of the question. It should provide complete description of the problem or the case, whatever you are using. And this is what I would like to really, underline. I put it in italics, but I would like to underline that include all qualifiers so that options don't need them. I'll show you some examples. But what happens is that because you have to make the correct answer include all the things to make it correct, so you are likely to make mistakes in creating good distractors. But if you add all that into the STEM, then a lot of problems are solved. I'll show you how you can do that. So include all the information for the question to be answered. Again, focus on application of knowledge rather than recall. And focus on important areas rather than trivia. Don't go on esoteric things. Don't go on things which require highly specialized care. Don't go to things which a super specialist only can do, because that is not the purpose of an MCQs. Now, cover the option test is something which I believe most of you have heard. Cover the option, and I also actually gave you that example when writing the question, that you write a STEM, don't put the answers and ask your colleagues to answer. Now, basically what cover the option test means is that you have the STEM, remove the options from there, and then see if this question can be answered. Remember how a student answers an MCQ? He reads this, he scans through his stored information, comes out with the correct answer, and then compares this correct answer with the options that have been provided. So same thing should happen here. Once you cover the options, the student should still be able to correctly answer that question. So this is actually given by NBME in its 2020 version of the recommendations. But what I found is that particularly in scenario-based MCQs, as I told you, there are 3 steps. So initial issue, then making a diagnosis out of the information provided, and then acting on that diagnosis. Now, most of the times, the question writers actually ignore the middle one. And so this is mine, and that is cover the STEM test. I'll show you what it means and how we can do that. Just one question to the organizers and audience. It might take another half an hour. So what do you want me to do? Break it or continue?
Um, I think we are all okay.
Yes, ma'am.
We are all okay with it, sir. Please go ahead. Because the flow would be broken if we take
Yeah,
a break.
because picking it up again on another occasion
Yeah.
would be a little
True, sir.
problematic.
I think we can go ahead, sir. Thank you.
I'll try to be a little brief on the subsequent slides so that we don't take too much of time. Now, here what I want to emphasize is not using these terms, none of the above and all of the above. Now, coming to the options. Your options should be on the same spectrum. So if your correct answer is about indications of a drug, then your distractors should also be about the indications. Or if you are asking about dose of one drug, then rest of the options should also be concerned about the dose of the drug. One of the very common mistakes that we make, and that actually tends to get exaggerated with scenario-based MCQ, is that we have correct option as indication, and first distractor is about the dose, second is about the toxic effect, third is about the interaction. Now, we should be able to put them on the same spectrum. And once you put them on the same spectrum, then you should end up something like this, that your correct answer is the most likely, whereas the other options are in a increasing order of least likely. But please remember, the spectrum is the same. So in other words, you cannot compare dose with indications, you cannot compare prognosis with treatment, you cannot compare surgery with medicine, that cannot happen. So it should be, and after all, see, you are writing MCQ. Have 2 MCQs, make 4 MCQs. What is there? You don't have to cramp everything into one single MCQ. You can always do it like this. And remember that if you do it like the earlier version, that is having multiple types of options available, you actually cannot put them on a spectrum like this. And therefore, the whole process of answering that question actually goes away from assessing the knowledge of the student to assessing his ability to guess the correct answer. So that will bring what we call constructed relevance, because you are assessing something which was not your primary purpose. Now, distractors, your own teaching experience can give you a lot of distractors, or as I told you about very short answer questions. So give a problem to the student, ask them to write one line or one phrase, and you can pick those up. Basically, distractors should appear plausible to the low ability students, and more plausible, the more attractive they are. But at the same time, you should avoid coming too close to the correct answer. I'll tell you why this can be a problem and how can you detect this problem, that you are too close to the correct answer. But please remember that the quality of MCQ actually depends on the quality of distractors. It's not how well or how good the STEM you have written. It's not how good diagnosis you have given. Rather, it all depends on how good distractors you have been able to frame for your question. Now, all or none of the above. In fact, what happens is that when you have written one key and 2 distractors, and the third one you can't find, so the tendency is to fall back on all of the above, none of the above. Then there's a problem with one of these. When you use none of the above, actually it decreases the item discrimination. And once the item discrimination decreases, the reliability goes down. In fact, Halladina says that both, all of the above, none of the above, actually decrease reliability. And you start measuring the guessing ability of the student rather than knowledge of the student. Look at this example. Now, using none of the above here may be the right answer. The student picks it up and he gets a credit for that. But it does not tell you if he knows the right answer, which is 0.1 ml. Now, does he know that? We cannot infer on the basis of this type of a question. But if you were to give a question like this, now here what he has to do, he should know what is the fluid requirement per day, say 100 ml per kg, and the weight is 12 kg. So the requirement would be 1200 milliliters, which is not there, so none of the above. So whenever you require a mathematical calculation, for example, none of the above might be an acceptable answer. Although the fourth one could still have been 1200 ml. But if you're so keen on using none of the above, then it could be when it requires some kind of a mathematical calculation. But otherwise, for recall type of questions, none of the above is a very disastrous answer. It lowers both validity and reliability. Coming to the next aspect, that is cover the option test. Now you have written this scenario and no options are provided. Would the student be able to answer this question without knowing the options? The answer is yes. Because dermatomyositis he can make out. So there is difficulty in climbing stairs, there's difficulty in swallowing, and there are macropapillary eruptions on the eyelid, nose, cheeks, and joint examination is normal. So dermatomyositis remains one of the best possibilities. So if a student can answer this question without going through the options or without even looking at the options, then you have written a good question. And in fact, that should be the first line of check. The moment you write a scenario, put your palm on the options and see if you can answer this question without looking at the options. If you can do that, then you proceed further and look for other things. But if you can't answer at that stage, then probably something is wrong in the description or in the options. Now I introduced another technique, cover the stem test. Now this is a question, 2-year-old male child presenting with puffiness of eyes, noted for 1 week, BP 140/90. Physical examination normal. He was given furosemide. Which of the following is a toxic effect of furosemide? Now, multiple issues with this question. One, that if you have a 2-year-old male presenting with puffiness of eyes, there is too little information for you to make further diagnosis. I need to know if urine contains RBC or not, because the child is definitely hypertensive. And he's showing puffiness of eyes and hypertension, but we are saying the physical examination is normal. So be careful about this, because you can always put in certain things which will confuse the student. Now, let's remove the stem. Can you answer this question? Yeah, we can. So what was the purpose of this? Nothing. So this is what I call cover the stem test. And by doing this, you are actually ignoring the middle part of the flow diagram that I showed you, that the student has to make a diagnosis first before actually going on to the next part of the question. So whatever information you have provided here has nothing to do with the leading. This question could have been simply asked, which of the following is a toxic effect of furosemide? Another question. 50-year-old man comes to a primary health center with chest pain located at the center of the chest, radiating into arm. History of discomfort, shortness of breath. ECG shows ST elevation. And you give the diagnosis, anterior wall myocardial infarction. How will you manage this case? Now, once you have given the diagnosis, again, let's look at this. If you simply ask this much, how will you manage anterior wall myocardial infarction in a 50-year-old man? Options will probably still remain the same. So all this write-up actually doesn't contribute anything to the diagnostic ability of the student. And this is what is called window dressing or irrelevant difficulty. Please remember, as of now, we are giving only 50 to 55 seconds to the student to answer a question. 3 hours, 200 questions. So less than a minute. And if he goes through all this, which doesn't help you in making a diagnosis, then actually it's a waste of time. He could have used this time more productively in some other question. So we can actually remove this off. Now, this question actually also provides an example of what I told earlier, that is convergence strategy. Please remember this term, convergence strategy. And once you learn that, this is in fact very interesting. Let's look at this question and look at the options. Now, if you look at the options, higher center, higher center, higher center. So 3 options have higher center. So most likely the one without higher center is not the right answer. And notice we are trying to do it without looking at the question. Second, you have high flow oxygen twice, but no high flow oxygen in this question, in this option. So even that goes off. So now you are left with two, high flow oxygen and refer, or high flow oxygen and these drugs. So aspirin and aspirin twice, clopidogrel and clopidogrel twice. So even this is a wrong one. So what you are left with, even without reading the question, you can actually answer this question. And this, I said, was my favorite pastime these days. Without looking at the question, trying to figure out the answer. And I am successful more than 95% of the times. Let's come back to this question again. Now, why did this problem arise? Because we used high flow oxygen in the options, some options and not somewhere else. We used aspirin in some options and not somewhere else. And we used higher center in some options. So what you should do is to take all these into the stem. So remove the diagnosis, let him make the diagnosis. So high flow oxygen, aspirin, and higher center go into the stem. Now you are left with only clopidogrel, and I'm not a pharmacologist, so I can't think of other options, but you could think of heparin or beta blocker or digoxin or something similar. Now it will become very difficult to guess. And it will also require the student to make a diagnosis which actually you had provided in the first version. Let's go to another one. No question. We'll just look at the options and see if we can come out. And this is the question taken out from the paper that I circulated the other day. Now look at these options: eosinophils, and eosinophil. This one doesn't have, so goes out. Next, this is the one with treatment. The all others are only lab investigation. So this one also goes off. And blast twice. This one doesn't have blast, so this also goes off. So even without actually reading the question, you can come out with an answer. And why did this problem arise? The same, because the examiner first wrote the correct option and then tried to manipulate that correct option into one of the various options. And that is what gives a lot of clues to the student to work on this. Now, lead-in is one part which is often missed. We write a problem, but we don't write the lead-in. In fact, lead-in is the task for the student, what you want him to do. So what is the diagnosis? What is the prognosis? What is the treatment? What investigations will you do? So these are the kind of things which should actually come in the lead-in. And as far as possible, it should be stated in a complete sentence in question form. It should be focused and clear about what is being asked and positively phrased. Don't put what should not be done, what is not the diagnosis, because that is not the way to assess a student's knowledge. It should always be positively phrased so that you know the thought process of the student. Now, look at another example. This is a scenario, and this is the lead-in, which gives a very clear task to the student. Look at the options. Now, these options actually require the student to be able to differentiate between a cardiac cause and pulmonary cause. For the same scenario, you can actually have a different set of options. And these options require the student to know more in detail about the pathophysiology of congenital heart diseases. So the same STEM can be used for undergraduates with these options and can be used for postgraduates with these options. So keep these in mind. The quality of options actually decides the quality of your questions. Another scenario, you have given one correct answer. In fact, if you want to use it for, say, MD radiology, you can actually change that without changing anything else. And generally, the recommendation is that one STEM can be used for about 4 or 5 different options. Don't use it more than that, because then it becomes difficult to, keep track of them and manage all of them in one go. Yet another example. So you can use this little history and focus on physical examination to come on some physical examination findings. Or you can actually focus on the diagnosis with the same information provided, and you can ask the student to make a diagnosis. So it is possible to really rephrase the STEM into little modifications, and you can change the format of the question. Now, coming to clang association, that is one important thing. In fact, I recently came across some AI generated or chat GPT generated questions. Apparently, common belief is that computer generated would be good questions. But if you look here, then laboratory investigations reveal elevated phenylalanine. The most likely diagnosis is. So you could unknowingly actually provide some clues, some hints to the student, and this is what is called clang association. To two things I discussed. One was convergence strategy, which I showed you some examples on how many times a phrase has been used in one particular option. And second is this clang association, which can actually give rise to this. Now, what I said right in the beginning about using assessment as learning. Now, this crowdfunding of MCQs, in fact, is a very useful strategy being followed by a lot of institutions and lot of universities. And multiple reports are appearing. You ask the students to write a scenario based on the case they have just seen and provide option based on the differential diagnosis. Of course, you can complement it by the peers and faculty. And there are reports to suggest that this actually results in a positive effect on learning. In fact, we all keep on complaining that students are more interested in NEET and entrance examination, and they don't come to clinics and classes. So using this strategy, in fact, can be one of the mechanisms to draw them to the classes where they write MCQs. And don't forget, you'll have 150 to 200 MCQs in a single class, which you can actually share in their WhatsApp group or in their Google groups. So this crowdfunding of MCQs is in fact very useful strategy and can be used by more institutions and more teachers. The checklist, you can actually click it and or maybe see it later rather than me reading through all that. Now, sometimes the STEM could be a problem. For example, we say that doctor prescribes syrup paracetamol, which is to be administered 4 times a day. What should be the minimum interval? Now, if you are saying minimum interval 8 hours, then you cannot have 4 doses in a day. So you have to be very careful about what you are asking and the small nuances, and as I said earlier, it is always the bright student who gets confused by these kind of things. He only will multiply. For a not so bright student, he'll pick up only this option. That's okay, without really going into how many doses and how many times in a day. I'll skip this. Okay. Now let's come to the important part, that is test and item analysis. Most of us have been doing item analysis. I'll not go into that. Discrimination index, of course, is one of the important things. But what I want to introduce you today, and I think many of the teachers have not really been exposed to this term earlier, and that is the horse statistics. What it means is the difference between the students picking the correct answer and the next best incorrect answer. Let me give you an example. A is the key or correct answer, and the next best answer is 24 students. So the difference 56 minus 24 is 32. Fair enough. Look at this. B is the correct answer, and the next best is 31. So 45 minus 31, 14. Okay. Look at the third one. B is the correct answer, picked up only by 14, but A is picked up by 56. So this goes to minus 44. Now it could either mean that the P is wrongly written and most of the students are misinterpreting it, or it could mean that by mistake, your typist has actually put a star on B when it should have been on A. And lastly, B is the correct answer, 55 pick it up, and 52 students pick up A. So difference is only 3. Now this is what should be worrying us. When you are so close to the correct answer, then probably there is some issue. You need to relook at the language, at the format, at what description has been provided, anything missing in the stem, because they are coming too close. And then probably it won't be a good idea to have a wrong answer coming so close to a correct answer. This is another graph. Many of you might have seen it earlier, that it requires at least 200 MCQs to attain a reliability of 0.8 to 0.9. Now that is what you actually target for selection test. For class test, you target for 0.6 to 0.7. So at least 100 questions are required. Now please remember that putting 5 questions or putting 10 questions actually doesn't serve the purpose. It's only a waste of time, and it only gives us a false sense of security that we have used MCQs. But in fact, we have not attained anything. At the same time, I want to clarify that when I say 100 questions, I don't mean 100 questions at one go. So even if you are giving, say, 25 questions into 4 times, that probably accounts for 100 questions. So make sure that you have a reasonably good number of questions. And the keyword here is that these questions should be with a discrimination index of at least 0.35. If your question is how many fingers a normal person has, or how many eyes a normal person has, then these figures are not applicable, because the discrimination is not there. You're not able to distinguish between a student who knows and a student who doesn't know. Now, time issues is another factor which you have to keep in mind. Right now, we have about 0.8 per minute. But if you are using a scenario-based question, then it requires at least 2 to 3 minutes to read, understand, answer that question properly. So from 3 hours, you probably need to move over to 6 to 8 hours with a break in between. Now, of course, these are all policy decisions, but keep in mind that if you keep, say, 50 questions and scenario-based questions and be happy with it, then probably they are not going to help. And lastly, scenario-based questions are not the only ones which can help you in making a good clinical diagnosis. In fact, very short answer questions, I've already elaborated, extended matching questions, key feature test, and most importantly, the script concordance test are the ones which are being increasingly used in many institutions. And in fact, it's high time that we also start using these kind of questions. They are much easy to construct, They are easy to administer as compared to scenario-based MCQs, and they have a better ability to help you in assessing the clinical diagnosis, clinical reasoning, and therapeutic planning. So thank you very much for being with me, and I would be happy to answer any questions that you have.
Thank you, sir. Thanks a lot. So many areas of scenario-based MCQ construction you have actually touched on. Dr. Josna, can you just look at the chat and moderate it, please?
We do have an interesting question by Dr. Seo. So he says, actually, we need to ignore the function of the vignette while framing MCQs for pharmacology, as we are not supposed to ask the students to make the diagnosis. How to frame it otherwise?
You know, this issue came earlier also. Chetna would remember when we were having this presentation 2 years ago. And again, same thing came that in pharmacology, we don't have to give the diagnosis. I don't think for pharmacology, you have a separate set of rules. It's the same rules which apply everywhere. And I don't know which authority has told us that you should not be asking the student to make a diagnosis.
Not that way, sir, but it does matter because sometimes it matters because the students may not be aware of all the signs and symptoms. So we need to actually choose different types of scenarios rather than asking a full-fledged case scenario where the student is required to know all the signs, symptoms, lab parameters, etc.
No, but even without knowing everything about myocardial infarction, you could still ask about antiplatelet drugs, and you could still ask about, I showed you some examples.
Yes, yes. In fact, mentioning the diagnosis actually does not serve the purpose at all of the
See,
MCQ.
that way, if we follow this logic, then that means no basic sciences will have a diagnostic question. Anatomy, physiology, so they are even younger. So it becomes very difficult.
Sir,
Okay,
I have mentioned one, this is related to that. In the comment also, I have mentioned that most of the times when the faculty are constructing questions, we look for algorithms. Like for this particular case scenario, this should be the signs and symptoms. This should be the lab parameters. But in real life scenarios, these may not be so true. So that is where when we peer review the MCQs, there's sometimes a sort of difference of opinion arising between the faculty. So how do we address that issue?
So the answer is that we have to contextualize the questions.
Mhm.
You know, these problems arise because we don't provide the context. Take a simple example. You have a case scenario, 9 months old child presenting with anemia. If he comes to me in Punjab, my first diagnosis would probably be to rule out thalassemia.
Mm.
He goes to somebody in Odisha or Bihar, they would probably like to rule out sickle cell anemia first. But going in, say, Ahmedabad or Mumbai, probably iron deficiency anemia would become more important. So I didn't want to bring too many technical terms. This is what in technical terminology is called differential item functioning. Okay, so same question actually functions in different ways. You ask what is the commonest cause of anemia. So the student in Punjab will write thalassemia, one in Odisha will write sickle cell anemia, Gujarat might write iron deficiency anemia. So that difference in functioning because of the context is what you need to keep in mind.
Okay, thank you, sir. Go ahead, Dr. Joseph.
There's another question. Does a negative question and scenario-based question good? Dr. Anil, would you like to clarify what you mean by that?
Uh, yes, ma'am. Am I audible?
Yes, you are.
Yes.
Thank you, sir. Thank you for the very informative and very nice presentation. It's really helpful for us. I'm from anatomy department. We
Would
give
you
some
Carry
questions
on.
that, yeah, we give some questions like that, like all the statements are correct except, or which of the following statements are not correct, something like that. So in that we give 4 correct answers, 1 wrong. With a scenario, if we give something like that, so is it considered to be a good questions or average or something?
See, remember the process of answering the question. The moment you read the question, the answer should flash in your mind. Once you have a which of the following is not, then there is no end to guessing. Na? That what is not. So that is the reason we don't prefer negative type of question. Except, in a very rare situation when you have something which is totally contraindicated. I'll give you some examples from pediatrics. I hope I'll be able to convey to you the meaning. If, for example, a child comes with kerosene oil injection and you are not supposed to pass a nasogastric tube. No, that is something where you would want to ask which of the following should not be done in that. Or if a child is born with meconium aspiration, then you are not supposed to do a bag and mask resuscitation because all that meconium will be pumped inside the lungs. So that is where you might want to ask which should not be done. But otherwise, there's no point of asking a negative question. We
Okay,
ask a
thank you.
negative question because it is generally very easy to ask a negative question. Try it next time. It's easy to frame a negative question than to frame a positive question. And that is the reason why many of us actually fall for negative question. But they don't help the student in learning, nor they help you in assessing the true status of the students.
Okay, we have one more question by Dr. Swati. So what must be the ideal practice to be adopted while framing scenario-based MCQ? Should we go with 5 options or 4 options or 3 options?
See, the current regulatory practice is to use 4 options. So I would say you stay with 4, unless for the next they change the number of options. If Avinash is still there, Avinash, are you there? Or has he left?
Yeah, soon.
Ah,
I
so,
heard you.
so can you actually elaborate on that, your paper?
Yes, yes. I think we had done this paper with Rashmi, and we had said 3 options are the best. But actually, as you know, India, we use 4 options. But sometimes that last option, people are very difficult to really bring in. They bring all that, no, none of the above and all of the above, which are absolutely useless options.
So since the regulatory requirement is 4 options, I suggest you stay with 4.
Okay, thank you for answering that, sir. Dr. Prasad Deshpande, you raised your hand. Would you like to ask your question now?
So my question is, in the scenario-based MCQ, what to do about providing source or reference to the answer key?
Good question.
See, most of the treatment that you prescribe or you pick in that question is actually based on some book or journal article or some source. You're not imagining out of your mind, what is the best drug for enteric fever. You have a book saying that these are the drugs which you can use for enteric fever, or what surgery you should be doing in this particular scenario. So you have a book reference to say what particular surgery you should be doing. I don't think there is any issue with getting references for the choices that you make for scenario-based questions.
Understood.
The
One has to
issue,
be as
see, the
close
issue
as
will be
possible. That is
if you
what I
make it
understand.
if you make it non-contextual, then you will have problem because suddenly you will find out how do I give reference to this. But if you are using a good scenario with
Yeah.
accepted principles of treatment as outlined in your standard textbooks, then you have a reference. I don't
Okay.
agree with that giving a reference is a problem.
So the reference has to be contextual. It need not be absolute word to word from the text.
Yeah, obviously.
Thank you, sir. Thank you, sir.
On that note, there is another question, sir. Should all MCQs be scenario-based?
It's a kind of tricky question. What I would say is that when you are doing formative assessment and teaching, so like I see a comment by Anshu that we have to correlate these mechanisms with the critical picture and teaching is disconnected with actual clinical practice. So in those scenarios, you can actually use simple questions. So
Okay.
if you remember that table which I had projected earlier, so one of the purpose of recall-based MCQs is to really catch the attention of the student and give him the important points. So that is the time when you should be using recall-based questions. But as the student keeps on progressing higher and higher in the curriculum, then keep on switching over to the scenario-based questions. And since your entrance examinations in coming future will have exclusively scenario-based questions. So probably you need to prepare your students well in advance for that.
Thank you, sir. Now, since you introduced the horse statistics, there's a lot of buzz around it. People want to know what is the range and when do you categorize that you want to change the answers to that, and etc.
I tried finding it out, but they have not given an ideal value. This much should be the difference. But as I gave you some examples, if you have a difference of 10, 15, it's okay. But if you are coming too close, there's difference of only 3, 4, 5, then you should be a little worried and try to modify the options.
Okay. So we'll hope to get some more literature on that. Sir, Dr. Khalid is asking a question. Aesthetics type of questions is for clinical scenarios. What would be it for basic science subjects? Anshu ma'am has answered it, but we would like to hear from you too.
No, I gave you some templates. You have a question on somebody injured his upper limb and now he's not able to lift the limb. Now that is an anatomy question, but given in a clinical setting.
Yeah. Okay. Thanks for that. That's all the questions we have in the chat box. If anyone else would like to ask a question, please raise your hand. Okay, we have one now. What would be the difference between MCQs framed, considering applying analysis and evaluation of the Bloom's taxonomy?
Mm-hmm.
With respect to the Bloom's taxonomy, we have the different levels, no, sir? So Dr. Vaishnavi wants to know what would be the difference in the MCQ framing to cater to.
See, the difference would be in the lead-in. What do you want to? So which of the following drugs would be better? So you have moved higher. If you say which of the following drugs would be used, then you are still at a lower level. So it would be depending on the lead-in and the task that give to the students.
Anshu ma'am has a question. How to frame questions on clinical decision making? We see very few of them in actual papers.
See, two reasons are there. One, that as you can see from the comments that I have in the chat box, many times, we still go with the idea that when we are asking questions in basic sciences, we don't have to follow the clinical scenarios to exact situation. My point is that why are you teaching basic sciences? You are teaching so that the student can become a better clinician. And if you are not able to make a student a better clinician, then it's no use having accumulated lot of stuff and facts about anatomy and physiology and pharmacology and so on. And
Okay.
second, that it requires a lot of effort. It's a unofficial story which I want to tell you. One of my colleagues actually went to one of the bodies. She was invited for setting up a question paper, and multiple questions were like this only, record type. One little stem and then 4 options. And so each option was actually a kind of true false statement. So the student had to do true false for each of the options to come to a correct answer. So when this person, I'm not naming, when this person said that this is not the correct method of doing, the chairman of that group told her, look, if we go by your method, then the student has to read only one paragraph, which is limited to what you are asking. But if you go by our method of this multiple true false, then he read the whole chapter. That is the mindset we work with, that you require more knowledge to answer a factual recall question as compared to answering a scenario based question.
Yeah. She has an add-on comment on that. What she says is that here we do not have the very clear clinical protocols, unlike in the West. So we might have multiple differing opinions in the practitioners.
But we are still teaching them. We are still teaching the management to our students, whether we have a standard protocol or we don't have a standard protocol. But most of the things, for most of the things we have. When we have a neonatal resuscitation, there is a protocol. When you have a dehydration treatment, you have a protocol. It's not that protocols are not there. They are there. And the fact is that you are teaching your students. So if you are teaching your students, then asking those things should not be a real issue.
Okay. Before I go to the question by Dr. Vikram Mohanty, Geetna ma'am, would you want to ask something?
Yeah, so just following up on the discussion that was going on just now, I think a more holistic approach where we do not have the silos of anatomy, physiology, pharmacology, medicine, that should be required, especially if we are looking for scenario-based MCQs. And maybe when there are these sessions for framing MCQs by all these bodies, where they should invite, we should have different experts sitting together to create an MCQ rather than subject experts creating their own MCQs. If that could be, done, that would be even better. I mean, it's just a school
So,
for
Jitna, we are all influenced by USMLE model.
that is
I
true.
remember I was once called by National Board of Medical Examiners to review 200 questions for USMLE. They transported 30 experts from all over the world to a resort in Portugal. Made us stay there for 5 days, and there we did all these questions. I hardly found any question on pediatrics over there. It was not subject based. They were looking at the general quality of the question and wordings and phrasing and options and so on and so on. But imagine the expense that they must have incurred. And it's a
Yeah.
costly affair. We can do it, surely, yes, we can. But the point is that it requires a lot of effort,
Effort.
money, and time.
Also, so I feel the scenario-based questions will sort of negate or sort of minimize one problem, that is students just memorizing options. We know students say that the option C is always considered to be a good fluke, or let us say they just read the stem and they remember this was the option in recall type of questions. Whereas this should be a little bit difficult in scenario-based questions. I don't know how far I'm right in that.
Yes, that is true, because there's no, question should be such that even if you have a book available, you should not be able to just copy the question and write it over there. And that is where the middle part, if you remember, that middle part of layered vignette, that is what becomes more important, where you require the student to apply that knowledge and then come out with some diagnosis, with some clinical scenario, and then proceed further. That is what is most important in scenario-based MCQs.
Thank you, sir. Dr. Mohanty?
Question. Dr. Vikrant wants to know, is there a distribution of scenario-based and multiple choice questions as per the current MBE guidelines?
Well, I have not read the NB guidelines, but all that I can say is that it's a policy decision. They need to decide how many have to be like that. According to me, all questions should be scenario based.
Yeah, I agree, sir. Okay, so that was the last question on the chat. Do we have any other questions? Chetna ma'am?
No, I don't see any more. How many of each category? Okay, fine. No, there aren't any more. So, with your permission, sir, we can bring this webinar to a close. We really thank you for accepting our invite for this webinar, and goes without saying that it has been excellent as always. And there's so much of learning when we attend your webinars, including this one. Thank you so much on behalf of AHP and all of us for this webinar, sir. Thank you.
Thank you.
Thank you,
so
sir.
much.
Thank you so much. I'll be ending the meeting
Thanks
now.
to all the participants also for patient listening. Thank you.